A few of you probably don't know Chip Hart, but I don't know how you could have missed him because he's been coming here and presenting regularly for years. And we appreciate that Chip brings his practice management consultation expertise to this group on a regular basis, really to help raise the performance of all of our practices. And we're thrilled to have Chip back. I think I just introduced you.
Oh, okay. I wasn't paying attention, sorry. I was getting,
This should advance.
this. All right. Well, I'm waiting for my mic to come on. There we are. Good morning, class. How is everyone? I'm tired. How many people here have seen me speak here before? Okay, so you know I come in and yell at you a lot. Today I'm going to try to be motivational is a little strong, but I do want to motivate you to do something. This isn't a motivational talk, but it's a talk to hopefully inspire you into some action. I actually had a stack of things I wanted to say before I started, and they all fled my mind. So I'm going to have to make it up a different way. What we're gonna talk about, just so you know, because you guys can't even see the screen. You have to look right at me. I'm sorry. All right, it's insurance contracting. Can you negotiate with insurance companies? And many of you in here say no. All right, we can't do that. And many of you in here say, I've heard of people doing that, but I can't be one of them. I belong to this network, and they do the negotiation for me. And there are a precious few of you who have actually done this and succeeded. So I'm up here to tell you that you can, in fact, negotiate successfully with insurance companies. I've worked with many practices who've done it. And the presentation you're about to see originally occurred at the AAP NCE last year. So at the SOPM Section H meeting, SOPM, the AAP, gathered 4 speakers to talk about the topic of insurance company negotiating. All 4 speakers had done the work, all 4 speakers were successful at it, and we each talked about different phases of the insurance negotiation process. And what I'm going to do right now is I'm going to repeat my portion. I was the first one of the 4 speakers. The speaker who followed me was Suzanne Madden, or Suzanne Brennan now. Then Paul Vanchieri, then Kim Brennan, no relation. And the 4 of us have worked with practice. Well, the first 3 of us are practice management consultants, and we work with practices all over the country doing this. And the 4th one is the practice manager for a large group in Florida who did it all on her own. And I'm going to give you my part. And yes, this is being recorded. You can see how I compared how I do today versus how I did this summer. Because unfortunately at the NCE, they weren't able to record it. So we got the band back together in July, and at the users conference for the company I work for, we all redid the presentation, and it was recorded, and all the handouts are there. And I'm going to give you the links. So you're going to see me live right now. You get to tell your friends, I was there that day that the world changed, all right? But you can also go and watch the remaining videos. I'm going to give you a link to it. It's all for free, all right? You just go online because we want you to understand the actual power that you have. So you are going to see the entire slide deck, but you're only going to get the first 25% of it. And then you're going to get links to the tools that we reference and the actual rest of the presentations. All right? Now everyone here is like, if I had known they were going to open with a coding talk and then an insurance negotiation talk, I might have taken my time getting here today. All right, it's rough. Jan, that's a tough road today. You open up but this is the stuff you need. This is like Jan and I and the speakers who follow, we are giving you an HPV vaccine. It's painful right now, okay? But it's better for your future. So that's what we're going to talk about. Oh, I'm supposed to disclose. I am none of those people, I'm the one at the bottom. I will definitely not be intending to discuss an unapproved, well, no, I just mixed the negatives. I will not discuss an unapproved investigative use of a commercial product or device in my presentation. I'm not going to discuss anything clinical. So the slide deck does not have, this is conscious, the official Children's National template, because I deliberately maintain the template from the original presentation, just so you, because I didn't want to put this template on and then you go watch the rest of it. The whole thing that would be kind of silly. And plus, I really wanted to underscore the fact that this is an originally AAP national content. The AAP is behind this, and I think that's important to understand. So, right there, okay, you have the handout. You don't have to take a picture, but you can. But if you have the handout, you can just click on those links. And the top link is a link to the entire presentation set, which you also have in your hand. And this next link, the YouTube link, is a link to the full, almost 4-hour presentation. Again, everyone here says, my idea of misery is a 4-hour insurance negotiation talk. But this is gold. And if you are going into work and you're sad about fill in the blank healthcare, okay, this is the talk that you need to start preparing to do the work. So the talk that I'm giving, this is CME stuff. At the end of this talk, you should be able to identify the data that you need to gather and understand to optimize insurance negotiations on payer contracts, all right? You should be able to create a strategy for managing contract negotiations with payers. And last, and definitely not least, you should feel confident in your ability to navigate different outcomes with payer contracts. I've got now like 45 minutes to make you feel this way. But we're going to do it. So here they are. It's the AAP slide. Round 1, I wanted to have a bell. Ding, because we all had 4 rounds of this. So here's the first, thank you. That was gold. Later today, whoever did that is going to get a gold star, and you'll find out what I'm talking about. All right, so there are a couple things I want to impress upon you. These are, when you are preparing to negotiate with an insurance company, these are 3 things I want you to keep in mind. These are 3 pieces, or 3 mantras I want you to repeat over and over again. The first one I want you to understand is, this is a business to them. They do not care about you or your patients. That was the friendliest way for me to write. The insurance companies are sociopaths. And I really mean it. I was working with a practice yesterday who was trying to formulate a letter to one of your local insurance companies. And she said, I want to write this letter. What do I need to put in this letter to make them pay attention to it and read it? And I told them, they're witnesses to this, you could put a picture of a middle finger on it and it won't matter. They don't have feelings. They don't care about your children. I have worked for decades helping people write these letters, and they provide data and they provide evidence, and they say, look, you are killing children in our town by not paying for this service. Can you just help us get this service? And they say, okay, now you're part of a process. We'll give you a reply in 90 days. Tell me, has anyone here ever written a letter to an insurance company where the phone rang 10 minutes later and they're like, oh my God, we had no idea? It's never happened, and it never will. And I'm not advocating against writing these letters. I'm just saying that you need to enter the space so differently from the way that you've been trained and you are wired to behave. Everyone in here is a massive empath. It's what you do for a living. You read people all day long, and you feel their pain, and you try to fix it. When you work with the insurance companies, you need to take that hat off, because that hat only makes you vulnerable. This is a business, and they only care about one thing: shareholder returns. That's it. So when we talk about this, I'm up here sounding like a jerk. I assure you, I am not the jerk, all right? But you need to start thinking differently. So when you do need to write that letter, you need to be blunt and you need to be direct and stop being nice. How many people here say please or thank you when they talk to Alexa? All right? Alexa doesn't care. It's the same thing. So that's number one. Number two, it's kind of like painting a house. The process is simple. It's not rocket science. It's just not easy. If it were easy, everyone would do it all the time. And the system is absolutely set up to be difficult. The insurance companies don't want to deal with you. Just think about it. This is Occam's razor. It's the simple answer. Why would an insurance company want to negotiate with you? They have nothing to gain. So you have to do the work. It's simple, but it's not easy, and the squeaky wheel gets the grease. Jan was up here talking about these new codes, and I'm actually really fascinated by the new telemedicine codes. And I'm going to guess, if I could take the temperature of everyone in here, about 10% of you are actually excited to use them and bill for them. All right? The rest of you are like, I'm going to wait for someone else to do it. Right? Am I wrong? Okay? But the thing is, if you all behaved the way that the rules say that you should behave, which is you should start billing that on January 1st because they have RVU values. I did stand up on the stage last year and yelled at you about the G2211. I did do that. And we're using it. Oh, I want to come down and give you a hug, all right? So the G2211, which has an RVU value, it is getting paid all over the country, not well or not consistently, don't get me wrong, but it does get paid, but it will not be paid if you don't bill it. And it will definitely not be paid if everyone in this room does not bill it. And so what I'm getting out here is if everybody is making the same noise, it has effect. So be the squeaky wheel. And then last but not least, and this is what I'm going to talk about, is that no insurance company, no one you're going to negotiate with is prepared for a pediatrician with data. They're just used to doing 1, 2, 3 magic. You've all read the book. You say to them, if you don't pay me more, I'm going to drop you. And the insurance company says, all right, okay, whatever. And you don't drop them. You are experts at teaching children or parents how to manage their children. And you explain to them, when you give them an ultimatum and you don't follow up, you just taught that child that the edge of the envelope just moved out another 20 yards. You all know this. So you get angry and I'm going to drop that plan. I'm going to call my rep. But then you don't actually put it in writing, and then you don't actually follow up, and then you don't drop them. And then the insurance companies, they just wait. Any threat you make to them, they just wait. Because as a rule, you don't follow through. So we're going to prepare you right now for the data you need to assemble to construct your argument. All right. The first thing you need to do, find your contracts. I love getting a phone call from a client. I need you to help me drop. I try not to name the company that's been in the news all the time, but I need to drop whatever, Cigna, okay? And I say, hey, because they're not paying me well. I say, okay, great. What does your contract say? Well, I don't know. Well, we're not even on the board yet. You haven't even picked your Monopoly piece. We can't play this game. Where are your contracts and what do they say? Because your contracts probably tell you when you are allowed to drop them. Some of them you can give 90 days notice. Some of them you have to give notice in a 1 or 2 or 3 week or 4 week window at a certain time of year every 3 years. So you might get all excited, but if your contract is auto-renewing, you need to find out when your renewal time is. Okay? So grab your contracts. And Paul Vanchieri has a cool little spreadsheet to help you get organized, where you can put all of your contracts in one place and provide the details of those contracts. So when you say, I'm just going to start doing my math, who do I want to drop? I'm just going to tell you, one of the coolest and most interesting pieces of advice I ever got from a practice manager was from Lynn Kramer, who was fundamental for the PPMA and one of the maybe, I don't know how you rank them, but one of the best practice managers I ever met, she said, oh, every year I just drop my lowest plan. She got so good at this, and it scared the bejesus out of all of her payers because she had no fear of doing it, all right? And what she had was she didn't do it in a spreadsheet, but she knew where all of her contracts were, and she knew exactly what the deals were. And you can see the details right here. You know, what are the effective dates? What are the plans that you're not contracted for? Who's their largest employer? Like, put this information in one place. When you sign that contract, just get it organized. This makes the whole process so much easier. All right? Number one. Number two, there are a bunch of financial reports that you should run. And pretty much every system now has the data that you need to run these, but every now and then there isn't something there. Who here has ever used the RVU calculator that I put out every year? Okay, a bunch of you. I'm like literally on my laptop in the other room. I have the 2025 one. I just haven't uploaded yet. Or take me 10. If you need it, just email me. I'll give you the link. But you should begin by examining, running a report showing the breakdown by CPT code of all the payments you receive from a payer. And go into, and you can use mine, it's free, but make up your own. There are other ones out there. They're not as good, but you can use them. I don't care. Grab an RVU calculator, because what I want for each payer is I want you to have a tool that says, for Blue Cross Blue Shield, here are my CPT codes, and here's how much I get paid for each of these CPT codes with a Medicare equivalent. So I want to be able to say, Blue Cross Blue Shield pays me on average 110% of Medicare, and Cigna pays me 125% of Medicare, and United pays me 95% of Medicare. And then for the non-RVU tools or procedures like vaccines, I want those I'll analyze in a slightly different way, but I want all of that in one place. This is the first place to start. This is where, now, and you do this for a variety of reasons. Number one, it's educational. You'll be like, oh, I didn't realize that they weren't paying me for this, or I didn't realize they were paying me so poorly for this, all right? It's also the language they speak. When you speak in RVUs, they understand it. So when you're able to say to them, this is the first time, when you say this to your rep the first time, there will be a pause on the phone. I'm looking at my data. I have the data. And you are paying me 97% of Medicare, and my other payers are paying me 110% of Medicare. They don't know what to say to that. You have them. The argument should be done. Reasonable people right away would be like, hey, you know what? Let's figure out how to get you to 110. But these are not reasonable people. They are sociopaths. Thank you. All right. So this is the first thing I want you to do, is start by gathering a per CPT level report that also summarizes how much you're being paid by that payer. Then, whoops, I lasered. I want you to break your payers down by visit type, okay? And at a visit level, I like this report because, take a look, all right? I changed the names, but this is just a random report for practice. I want you to count up last year. How many visits did I do with Blue Cross Blue Shield? How much did I charge them on average? And how much did I get paid on average? This will tell you how to prioritize your payers. If you're getting $220 a visit and $220 a visit and $220 a visit and $170 a visit, $170 is where you're going to start. This also gives you a sense of their overall impact on your practice. If you're going to kick them out, what kind of revenue are you talking about losing? And you're not going to lose that whole thing. We're just talking about what kind of divot do you have to fill. This is a fast and dirty way to do this. And it's easy to do. Every one of you has the ability to count up visits, total dollars charged, and total dollars paid for a payer. So drop that into a spreadsheet and make this, start mapping out who is going to impact your practice the most. Does anyone have any questions so far? I don't know if I talk fast enough and loud enough, I can keep you all at bay. All right. Now, I then want you to go learn things about your practice before they tell you. The more you know about your own practice when you're having a conversation with them, the stronger your negotiating position is. So start running clinical reports. And these clinical reports include, right at the top, you need to find out from them every possible quality report metric that they might use, they are using, everything. You need to understand where you stand with them on all of their quality reporting metrics all the time. There are people in this room who I know who have been burned by this because they work with a payer who only gives you quality metrics reports 6 months after everything happened, and you can't fix the problem then. Oh, I didn't realize I was supposed to be billing that CPT code. Are you guys familiar with this? All right. I actually was working with a practice last week where they only get their quality payments. Get this, they just got their quality payments for 2022. That's insane. One of the ways, reasonably, to resolve that is to get as far ahead of it as possible, so that you know coming in that you are not in a passive situation waiting for them to give you your report card. And report cards trigger every single person who went to medical school, all right? You all are triggered by the idea of a report card. Write your own report cards. And you need to be prepared in this negotiation to say, I give myself an A+, because I have a 99% HPV coverage rate. I have a 95% well-visit coverage rate. I do depression screenings on all my teens. Show me, you need to be prepared to tell them, show me what I'm missing. Show me how I am not the best practice in your entire network. We're not saying that yet. I am gathering ammo, okay? Next thing I want you to look at is just what I spelled out, your well-visit coverage. How good are you at getting your infants in? Everyone here is good at getting their infants in. You're all at 95%. But a lot of you in this room are not good for the kids who are 7 to 11. And a lot of you are really not good at the adolescents. I've shown the benchmarks in this room at least 3 times over the last decade. All right, and I know this might be Lake Wobegon and everyone is above average, all right? But the average practice in this room, 1/3 of your teenagers haven't been in the last year, all right, for the average. So you need to know that before they say that to you. It's also, just as an aside, a good opportunity to improve your scores and get yourself better. It's not only good for your practice financially, but it's really good medicine. Rewinding my talk from 2018 in this room. Okay, we've talked about this a lot, but that's what you want to know. One number that I want in my back pocket at all times is I want all the 99051 volume, all the visits you did on weekends or after hours. Because chances are you're not getting paid for it. Or if you're getting paid for it, you're getting $5. All right, and some of you are like, I don't bother to bill it. Well, if you don't bill it, you can't count it. And when you're going to sit down, these are the sections rounds 2, 3, and 4. And you're going to sit down with fill in the blank, Blue Cross or Care First, and you're like, I need to get paid for after hours codes. And they're like, well, I don't know why. No one bills it. No, you're the first person who's complained about this. That's, by the way, that's when you know they're lying, but whatever. You say, you're the first person who's complained about this. Well, if you say, well, I do after hours all the time, that's no argument. If you say, I did 1,142 visits after hours last year for your patients, and I'm going to send them all to the ER if we don't figure this out. And I think after the second person I send, the amount of money that we're talking about right now is now all in my favor. Because most of the time, well, just as an aside, most of the time, on average in a practice, the amount of money you're trying to swing a contract is $50,000 to $100,000. How many kids do you need to send to the ER instead to hit a $50,000 or $100,000 bill for Care First? Not many. So you have to count them. You can't just say you've been doing it. You have to show them that you've been doing it. All right. I want you to look at your immunization coverage. I want you to look at your ICD-10 counts. It's a weird thing for me to suggest, but how do you think the payers are doing all of their quality measures? They're looking at your ICD-10s, your SNOMEDs, and they're looking at your CPT codes. I mean, depending on how the payers are gathering data from you. And right now, if you've just been putting that one Z code on your well visits and moving on, you are creating a profile of yourselves that shows you have a very low risk practice and you have, you don't have much of a challenge clinically in your practice. You need to start counting and looking at the ICD-10 codes that you are putting on your visits. All right? And then last but not least, your telemedicine volume. Jan just gave you like the first chapter. It's actually now the second chapter because the feds have been pushing some of these telemedicine codes for years. And of course, a bunch of the payers stopped paying for them post-COVID. That's all nonsense. Does anyone here need more proof that the payers are sociopaths than them dropping all the telemedicine payments after COVID? I mean, that was just insane. Like, look, guys, we are saving you money. But they're like, no, not really, because now they're not going to get a visit at all. So here you are practicing better medicine, and they just want to cancel it over a $40 charge. Is there a single payer in the country whose ship is sinking because primary care decided to do telemedicine? This is ridiculous nonsense that we're even talking about this stuff. So my point is, you need to start, even if you, please start billing it. So the only way you're going to prove that you did these things is if those 20 plus new codes, plus some of the old ones, are in your system and part of your data. Well, I did 500 telemedicine visits with your patients. I could have turned those all into 99214s and 215s if you wanted. Or I could have done none of them and some of those kids would have shown up at the ER. What do you want? Which is it do you want? I am your cheapest answer and your best answer. I mean, what more proof do you need that they are not actually trying to be efficient here? They are trying to squeeze every portion of it. They want your table scraps. Someday I will say what I really think. And then they're going to find me in the back of a black Cadillac down by the river. All right. Step 4, demographic reports. I want you to know and understand your patient base better than anybody. I want you to run reports and know I want you to understand the distribution of your active patients by age. I want you to understand by sex, by race, by language. I want you to do that for each of your payers. I want you to discover, like, oh, it's really interesting. I've got a very different demographic distribution for this insurance company than that insurance company, because it does happen. And when that happens, you want to know it. You don't want them to. They know. Just because, they legally share all of this data all the time with each other. It's only illegal for you guys to share it. I mean, this data is legal to share. You can tell anyone, like, I've got a 60% gender imbalance in one of these pairs. There's nothing illegal about that. But they know, and you want to know this before they do, because it might change the way that you actually you practice medicine. I also like having people keep track of things by zip code, so you know where your patients are. And then, arguably, one of the most important points that I want you, or one of the most important pieces of research that I want you to do, is I want you to track who the employers are, the major employers, for all of your payers. If you've realized that, geez, a lot of my Blue Cross Blue Shield patients come from this law firm or this .com or whatever the case may be, when the time comes, one of the first letters that you are going to write is not to Care First and not to Blue Cross Blue Shield, but it is to the HR person over at that .com to say, hey, I just wanted to let you know, I've got about 25 of your families, and I'm kind of in a little bit of a pissing match right now with Care First. And if this doesn't work out, 25 of your employees are going to probably have to find a new pediatrician unless you switch coverage to Blue Cross Blue Shield. All right? Because and nothing will cause the sociopaths to pay more attention than a phone call from the people who pay them. One phone call, just one phone call from one of your local businesses to one of these payers will do more for you in your negotiations than anything else you do. Herb, did you have something to add? Oh, you're going to have to yell. I don't know if there's a mic around here. Oh, sorry. They're going to get you a mic. Let's see if he can catch. Right. Okay, there you go. Sorry. Yeah, it's good now.
Hi, I'm Herb Bravo. I'm the co-host of the Pediatric Lounge podcast for pediatricians. Chip, wonderful talk. I think that's the key that you just said. Talk to the employers. And the other thing that you can do now that is totally legal, the health systems have to report what they charge for 99213s, 99214s, and what they're getting paid for the pair. And when you write that letter, say, my friends at John Hopkins are getting paid this for a 99213. I'm getting paid this. You're paying this much less every time your employees come to see me, and I give better care.
Right. And you can make the argument, hey, I'm not shooting for Hopkins payment levels. I mean, it'd be sweet. Can we split the difference? I worked with a practice yesterday. I don't know if you know this. I was surprised you all don't know this. Every single hospital in the country, by law, has to report what they charge for every procedure. Did you know that? If you go to any hospital website and you type in the name of the hospital, I didn't do this yesterday, but I was in a local hospital building and I typed the name of that local hospital building and price transparency, and it brought me right to the webpage that they're all required to have, and there's a big spreadsheet in there. In this case, it was a 300 megabyte spreadsheet, and right in the middle of it, I will tell you what I found. I was working with a practice. They charge $153. Now, this is charges, not payments, okay, but so there's a difference. But the practice charges is about $150 for a 99213, which you all charge about $150 for a 99213. And I said, did you understand? Because here's the file, because it's publicly required. Here's the file that shows the doctors floor over or 25 feet through this wall who are employed by this hospital. When any one of them, when they do a 99213, they're charging $394. And the implication of that, of course, is they're getting paid a lot more. That's public record right now. During break, get on your phone, type the name of your favorite hospital, and then type price transparency, and it will bring you to a website and you can download them. Just as an aside, because I can't help myself and I love talking about it, on average, in this room, you all charge about 180% of Medicare. Or 180, okay? Some of you charge 120, which is crazy. Some of you in here probably charge 210, 220. I'm just guessing, but I'm pretty good at this game. The hospitals, on average, charge 600 to 1,200% of Medicare. That $153 for a 99213 is, in fact, 180% of Medicare. So if I tell you that the hospital charged, what did I say, 350-ish or something like that, that's obviously 360%. It's twice as much. I mean, my math yesterday was a little bit more than twice as much. It was like 394. So it was like they are charging roughly 400% of Medicare for that procedure. So here's the thing. None of that matters. It should never matter. The way that the RVU system works is that regardless of your specialty, a 99213 for a cardiologist, for internal medicine, for pediatrics, it's all the same amount of work. A brain surgeon should get paid more because the education and the work required to do brain surgery is reflected in the codes for brain surgery. But if you take a cardiologist, and if an adult patient is seeing a cardiologist for follow-up care, which happens all the time, and someone gets sick and they come in and the cardiologist does 10 minutes in an exam room, yeah, you've got a virus, do this, do that, that's a 99213. You should all be paid the same amount for that procedure. But you're not because the hospitals and the health systems, and this is where the little shock collar, I get zapped in a minute, but all those big payers, all those big organizations, they leverage their weight and they get paid more for the same work. The work RVU concept is literally, this is how much work it requires. It is specialty independent, but in reality, it is not. And one of the things that, I'm definitely going to let Sue talk, but one of the things that Herb brought up is this information is now public, and you can actually see in any town in the United States, if you say, tell me what this multi-specialty group, this hospital group, and this pediatrician's practice are being paid for the 99213, you are going to see three different values. So, Sue Cressley. Wait. Sue Cressley.
Sue Cressley, President-elect for the Academy. Thanks, Chip. Couple of things. Data is power. And if you download that file, it's going to look like gobbledygook and you're going to decide that you don't know what to do with it. There are lots of really smart informatics type geeks that can help you parse that, figure out what data, what information you want out of that, like what do people charge for 99213s and 4s, or pick specific CPT codes that it's easier to figure out, especially if you're in a competitive environment. The other thing that you should know is you think it should be paid the same, and it's not. There's at least one geographic area in the country where family docs are getting paid more to take care of kids than pediatricians. And that's because there's a shortage of family docs. And so the payers have put a huge premium on their payments, but they carved out the pediatricians in the process. So knowledge is power, knowing what everybody else is getting paid so that you can advocate strongly.
Yep.
It is not the same across the country. You all have unique problems to solve, but we have to figure out how to get the right information to make that happen.
And I will underscore that point with the feds try hard to move money into primary care. The G2211 is a great example, but there was a much bigger example that happened in 2021, but it went right over our heads, went right by us. January 1st, 2021, the feds jacked up the RVU values for 99212 through 215, an average of 25%. Just as an aside, I did the math. If you all got 25% more revenue for your E&Ms, I think it was like an extra $30,000, $25,000 per doctor in this room. That's frosting, like there's no extra overhead, same work. And the feds moved all that money. Every single doctor who takes Medicare, boom, instant raise. And they felt it. Did anyone here get an extra 25% for their E&Ms on January 1st, 2021? No. All right, unless maybe you negotiated it. But the thing is, let me ask you this. How many of you in here know what year your RVU, what year your contracts are using for your RVUs? Because you're all paid on RVU contracts, whether they state it or not. Does anyone know, once the last contract you opened, they said, we're going to pay you, the percentage doesn't matter, we're going to pay you 90% or 150% of what year? Does anyone know? Yeah, Rachel. 2020. It is incredibly rare right now to find a pediatric practice in this country who has a contract after 2020 for this specific reason. Now keep in mind, the rest of the world is on 21, 2, 3, 4. And if you ask the payers, they will straight up say, oh, we don't move anyone to 21, 2, 3, 4 because it's too expensive. So the feds did create a map, but because you don't take Medicare, and because Medicaid is not directly tied to Medicare, because someday we are going to climb that mountain and plant a flag at Medicare for Medicaid at Medicare rates for every kid, and the difference in this room is profound. All right? I see two people in this room who are sleepless at night sometimes thinking about this, because this is the difference. The difference between why are pediatricians suffering so bad? Why? You guys got me on a rant. It's 9 o'clock. All right. Pediatricians are suffering more than the rest of your peers, at least in this regard, because on average, you're about 30, 35% Medicaid, which on average pays 30 to 50% less than the lowest bar for all of your peers. And if that gap were filled, we would be complaining about something else, but we wouldn't have people fleeing this specialty like they are. Jesse Hackle gave a presentation at the NCE which showed there are fewer people entering pediatrics than are leaving from retirement or just leaving the profession right now on an annual basis. That makes everyone sad. Part of me says, well, hey, our leverage is only going to get stronger. It's harder work, but just like Sue said, in terms of like there are parts of the country where the FPs are, understaffed. Well, that's about 95% of the US for pediatricians. Just as an aside, you guys happen to live in one of the most over pediatric parts of the country. I'm sorry to tell you, you can't throw a brick down here and not hit a pediatrician, but we'll figure that out. You still don't have enough, but it's relative. It's all relative. All right. I think I only have one or two more slides and I'll take questions. And I can poke a little bit at the slides that are coming up. I also want you to do benchmarking. I have handed you benchmarks. I've given you benchmarks. And you can find them on my blog, or you can go look up last year's presentation, because I think that's what I did last year, maybe 2 years ago. Because the benchmarks actually don't change very much. You want regional, national, HEDIS, public. You want all the benchmarks you can, because you want to be able to say, this is my E&M distribution. This is what everyone else looks like. This is my sick to well visit ratio. This is what everyone else looks like. There are some really good sources of pediatric benchmarks that are out there and available for free right now. Or like to civilians, like we are, okay? And you want to know how you perform. And obviously, if you discover a benchmark where it looks like you are not performing, one of your first obligations is to get your act together before you go to the table. Because they will find it and they will pull that thread and you will feel it. All right? Then, this is one of the fun things I like to do. First of all, actually, I needed to make 2 slides for this because this really gets distracting. The first thing I want is vignettes about your practice. This is something almost no one does. But when you have in your practice an amazing moment, okay, everyone in here who got into pediatrics, if you've done this job for even a couple weeks, you have had a moment with a patient that reminds you why you do this work. You've had a profound effect on a family. You've put them on a different path. Their future is now different because you were able to discover something or communicate something or fix something or help them understand something about themselves. That's why you do this work. Write it down. That's a story. Stories are more important than data. I'm up here telling you how important the data is. The stories are more important. And if your patients have that story and your patients are willing to say, they send you an email because you have gotten those emails. Not every day, but if you've practiced long enough, you've gotten that heartfelt response from a family. Thank you, Dr. So-and-so. You changed my life. I'm going to love you forever. Save that because that needs to be part of your argument. The thing that you have that the only reason the insurance companies want you at all, because they would replace you in an instant with AI. They would do it tomorrow if they could. It's not even a question. The reason you have one thing that they cannot do. You have a relationship with the families. That is the most valuable thing you own. And so you are going to want to take those relationships, document them, and turn them into narratives so that when it comes to when you are going to do the work that are in the next 3 sections, you have these narratives supporting all of these things. It's one thing to say, I have the best HPV rate in town, and look at what my patients say about me. Because that's the thing they can't replace. But then the other thing I want you to do, this is why I want 2 slides, is just Google. Because every one of these plans reported record earnings during COVID. Every one of these plans did. The best time to have been an insurance company in the United States was in the middle of a pandemic, an international pandemic that killed millions of people. It's weird. But that's because it's a financial system and it's designed that they win, that their house wins every time. So in your narratives, not only to them, but to your patients and to your employers, you're going to say stuff like this. I blocked those out. So if you can actually figure out how many characters that is, you can probably guess who it was. All right. So-and-so reported a $5.6 billion, $5.6 billion profit in the first quarter. That leads to an estimate of maybe they have a 20 billion profit. That's not revenue. That's the money left over. And insurance companies actually do accounting differently legally from all other businesses. So their definition of profit is actually even an underestimation compared to your version of profit. They made so much money. And you're like, I'm just trying to see more kids and you won't let me. I'm just trying to give more vaccines and you won't let me. I'm trying to do more well visits and you won't let me. Explain to me how this decision for my practice and the 1,500 kids or 500 kids or 5,000 kids who I see with your insurance company, explain to me how this hurts your $5.6 billion profit bottom line. And they don't care. Remember, they're sociopaths. You can say that to them, that they have no shame. But when your patients see this, and you've sent a letter to all your patients saying, I regret to inform you, but our discussions with whatever health group have come to an impasse, and starting on March 1st, 2025, we can no longer accept this insurance company in my practice. You have a couple options. You can still come see us out of pocket. We would love to see you. We've loved being your PCP all these years. You can switch to one of these other payers with whom we still participate, and that's the best one. But by the way, you might be interested in these following articles from Forbes and Wall Street Journal and everything else to give you a sense of what we're up against as an independent practice. And here's the phone number and email address of the patient rep for our county. And here's the phone number and email address of the CEO, the new CEO. Here's the email and phone number of the address for every single person that you can name in the C-suite. And they hate that. But it is totally and completely legal. That's the company they are doing business with. You're like, I'm the CEO of my company. You know my email address. You know my phone number. You know who I am. This is a business arrangement. Here are the people you can contact to complain about this. And everyone in here is like, yeah, that sounds great. I absolutely mean what I say. You are also patients. You also have healthcare. You have also entered the healthcare system. And you are 1,000 miles ahead of all the other civilians who enter the healthcare system. You know more about what's happening when you arrive at some other practice's front desk. And correct me if I'm wrong, it is still absolutely arcane and bewildering and overwhelming. Anyone here who's been to a doctor on behalf of a family member or for yourself, and you've all said, oh my God, thank God I know about that. I know what to do here. Like, you all done this. What does someone who doesn't understand what the doctor's saying, how do they get out of here? And so I'm saying the same thing, you need to bring your patients through the process of any decision they'd have to make like this so much farther, because they don't understand. They don't understand that this company is the devil. They don't understand that at all. They were just assigned the insurance company by their payer or by their employer. And some employers have decisions. And if you can make the decision, if you can drive them to a right decision, you've got to explain it. They don't know. All right. Now, this is where my deck ends. And if anyone has a question, I'll take it. But I'm going to show you a little bit what's in the other decks and what you might get from, or what you will get if you watch any of the other presentation. But I'll take some questions just to make sure. So please.
Good morning. I'm Kim Kelly Robinson from Kim Kelly Pediatrics. My question is, formulating that letter to the parents, is it better to do that during the open season? Or does it matter?
So that's a great question. First of all, I don't want you to overthink it, okay? What I mean by that is, if I go back to the slide that talks about the contracts, all right, the first thing you have to do is find out when you can get out of this contract. All right, so if it's 90 days, if you can get out with 90 days warning, then the timing is going to be entirely dependent on you getting your ducks in a row, okay? Presuming you've decided to negotiate and or leave this payer, okay? If you have a window during which you're allowed to do this, like because some of your contracts will say you can, if you don't want this contract to renew, you need to let us know between November 1st and November 30th of the third year of the contract. So you have to find out what that window is, and that is going to set your timing. I mean, it is, and you're listening to me say this going, wait a minute, that's so crazy and difficult. That makes it so, the timing is entirely up to them. That's on purpose. That's deliberate. So you need to get your contract and find out what it is. Now, I am definitely not a lawyer. Some of you in here, as you go prepare, are going to learn that you don't have your contracts. You don't know where they are. I guarantee in this room, 30% of your contracts are missing, or at least missing from your side. You will need to call them, many of you, call your payers and say, I need a copy of my contracts. More often than not, they're going to say, we don't have a copy of it, which is just as an aside, that is insane. All right. And it is so common in our business where two entities literally don't have a business contract, but one of them somehow has all the power and holds you to all these rules. But we don't have a contract. I mean, it happens. I bet there are 10 practices in here who are getting paid on a fee schedule that's never actually been documented. 10, it's half of you. All right. So if you can't get a contract and you don't know what your window is, you have to get from them you have to get in writing from them what the window is. Okay, I understand you don't have my contract. I understand you don't have this. If I need to drop your plan, when am I allowed to do that? And whatever you get back in email, you're going to save, you're going to memorialize. Thank you for this. I'm going to memorialize. My understanding of your email is I can negotiate, or I can drop your plan here, and I will intend to move forward. I'm saving this message for future reference. That's the timing. Otherwise, yes, you want to get your stuff out before open enrollment because if people can switch, you want them to switch. But it doesn't happen that much often anymore, unfortunately. All right, I got 5 minutes. I've got a question here. And while I'm talking and while I'm answering questions, watch this. I'm going to do this. I'm going to slowly go through the other slides and just tease you. Okay? All right, Suzanne's deck is awesome. All right, Paulie's is funny. He's like I am. He does the numbers. But I'm going to tell you the secret weapon of this entire thing is Kim Brennan's was inspiring. All right, oops, I heard a couple yet. Did people see this? Okay, this is gold. So watch Kim's. She walks you through it, and I'm just landing on one thing. She's got sample letters, sample proposals, termination letters, patient letters. She did. And I'm just going to leave this up because you guys can't help yourselves. You always take pictures of the slide decks. There's a whole section at the AAP website about this stuff. And yeah, her spreadsheet was gold. Oh, you want me to go back to that? Okay. So I'll take that question. Yeah, I'll leave that up there. Dr. Hirsch.
Hello, so I'm Stephen Hirsch, a pediatrician in Rockville. Montgomery County Public Schools is an enormous employer in Montgomery County. It's huge. And they changed their contract from Care First to Cigna, which for probably many practices was not a very good change. If MCPS is self-funded to the plan, can Cigna negotiate those rates? Or will they just put it back on MCPS saying they self-funded? Or would it just come out of Cigna's pocket because they would make less if they pay you more? That might be in the weeds. I don't know.
So that's a really interesting and complicated question. And I can tell you, I can give you my answer, but I don't, Herb is going to give an answer, but as it gets, you know what? I'm going to shut up and let people who actually know the answer. Sandy Chung will have some advice. By the way,
It's a great question, Stephen. So basically, when a self-employed employer uses a TPA like Cigna or United, they put in the hands of that TPA the negotiation power. So when you're negotiating with Cigna, you're negotiating that contract as well.
Yeah.
About 65% of employers are self-funded. So chances are most of your patients are on self-funded plans.
And due to, what would we call it, a loophole? The self-funded plans don't have to follow the ERISA laws, which cause all kinds of other coding and payment problems. That's a whole other 45-minute discussion. Herb Bravo's got one more comment, and then I'll be able to take one more question.
So the first thing you have to do is the school systems have something called teacher unions, which are extremely powerful. So my experience when I owned the urgent care in Northern Virginia was Loudoun County went to Cigna. They're just like Montgomery County. And I got paid more out of network than I did in network because the teachers unions negotiated a contract that if they take their kid to an office that's out of network, they're covered at a $25 copay. So you need to dig deep first before you sign that contract.
Hey,
All right.
hey, Chip, I've got the mic over here for one last question. Way over to your left. Your left. Hi.
Oh, really? Okay, sorry.
Mike Hopper, I'm a pediatrician in Alexandria.
Yeah.
Thanks for a great presentation. I'm hoping that Mark and Priya, when they talk later, they're going to talk a little bit about what the PHN is doing on some of this. Is that true, Mark?
Yeah.
Because I think that this talk like this is encouraging, but it's also depressing in terms of how much work it is.
Yeah.
And we've done it before. Our practice has had some success. Years ago, I listened to one of your talks and then got all fired up, and we did this with one of the payers. And whenever we've done this and it's been successful, it's only when we gave the letters that we were walking away. It never was successful before that.
The overwhelming majority of successful negotiations my clients have had occur after they drop the plan.
Yeah, and it's hard. So you have to realize that this is hard, and that's partly why this PHN network is working a lot right now on contracting, and because it's not easy for any of us, and it doesn't make a whole lot of sense for every single little practice to do this on their own.
Right.
So I'm hoping that Mark and Priya are going to share some of the successes the network's been having, and we're all hopeful that there's going to be more successes coming. So thanks.
No pressure.
Right there in your own practice, as Chip and others are recommending, you've got to look at your own data. You've got to look at your own contracts. And most of us who are clinically focused don't spend a lot of time on that. A few of us are champions in that space, and we often work with practice managers and leaders who are really, really good in that space. But that's part of the reason we get together here as a group. So I think what Chip is advocating, which is know your contracts, know your data, look at the gaps, develop a strategy, is absolutely spot on. We should all be taking notes. And we'll talk a little bit about opportunities that bigger groups might have after the break.
All right.